Hello, and welcome to our Cottage Meet the Doctor virtual event featuring Dr. Courtney Stull, who will lead a conversation on the keys to joint preservation as we age. I'm Christina Cortez, Public Relations Manager for Cottage Health and your moderator for this session. Before we get started, I'd like to review a few housekeeping items to optimize your viewing experience. At the conclusion of our presentation, we will host a brief question and answer session. Please use the Q&A button to submit your questions for Dr. Stull. As you submit your questions, please keep in mind that to protect everyone's privacy, we aren't able to address individual medical conditions and medications in this setting. We're happy to speak to general topics and guidance that may be helpful to the group. Lastly, this webinar is also being recorded and will be emailed to you. So it's now my pleasure to introduce Dr. Courtney Stull. Dr. Stull is a rheumatologist with specialized training and experience in managing complex autoimmune conditions. She is board certified by the American Board of Internal Medicine in both rheumatology and internal medicine. She earned her Doctor of Medicine degree from Sidney Kimmel Medical College at Thomas Jefferson University in Philadelphia. Dr. Stull completed her internal medicine residency at the University of Colorado in Denver, followed by a fellowship training in rheumatology at the University of Pennsylvania. Prior to joining Cottage Health, she provided specialized rheumatologic care at Margolis Rheumatology Associates of UPMC and at Lankenau Medical Center of Mainline Health in the Philadelphia region. Dr. Stull has authored multiple peer-reviewed publications and presented research at national rheumatology conferences. She is committed to improving access to high-quality rheumatologic care throughout the region. And now, please join me in welcoming her.
Good afternoon. Thank you all for joining. I'm going to be speaking about osteoporosis, and thank you for the introduction. So an outline of our time together today, I want to define osteoporosis, discuss risk factors for osteoporosis, review screening and monitoring recommendations, discuss both non-pharmacologic as well as pharmacologic therapies for management of osteoporosis, and leave some time at the end for questions. I have no disclosures. All right, so to begin, osteoporosis is a disease that weakens bones, making them fragile and more likely to break. Think of osteoporosis as a bone becoming more porous and less dense. Like in this picture here, this is healthy bone, and over here in B, this is osteoporotic bone. So you see it's like a sponge with larger holes. And osteoporosis is a silent disease. So really there are no symptoms until a fracture occurs. And then there can be symptoms obviously associated with the fracture. But up until then, it's really a silent process. It is also preventable and treatable, which we'll spend a large part of the time today speaking about. Why do we care about osteoporosis? So the main reason is because of the impact of fractures. So fractures in the context of osteoporosis, you'll sometimes hear the term osteoporotic fractures or fragility fractures. And this term refers to fractures that occur spontaneously from mild trauma. So fractures from the equivalent of like a fall from a standing height is often what we consider for this. And they occur, the most common site for osteoporotic fractures is in the vertebra. So like a compression fracture in the spine. Also the hip and the wrist are common sites. We also could consider an osteoporotic fracture in the humerus or the arm bone, the rib, and the pelvis. Typically, fractures that occur in a finger or toe are not considered second to osteoporosis. So beyond the definition of what an osteoporotic fracture is, the significance of them can be great. Fractures can be very painful, both in the acute and subsequent phases. They can cause reduced mobility and independence related to that. You can have, if there's a compression fracture or fracture in the spine, it can cause a loss of height. In addition to quality of life, it can also contribute to length of life. So there's an increased mortality, in particular, with regard to hip fractures. So there's about 20% mortality rate in the year after a hip fracture. So very serious, specifically with regard to the hip fracture. And then also very importantly is the risk for subsequent fractures. So a first fracture is thought of as a sentinel event, so indicative of underlying bone disease and weakened bones. And there's a higher risk for subsequent fractures. So it's sort of the time to act, if not ideally before, but there, with regard to vertebral fractures, which I mentioned are the most common type of osteoporotic fracture, there is a 5 times greater risk for additional vertebral fractures after the first, and 2 to 3 times increased risk for a non-vertebral fracture. As far as the epidemiology of osteoporosis, so very common process. Greater than 12 million Americans have osteoporosis, and there are more than 2 million new osteoporotic fractures every year, and this number will likely increase. Just based on population. Hopefully, people will get therapy and not increase. But it is most common in postmenopausal women, and the risk does increase with age. Some of the risk factors, there are certain that can be controlled and others that are not modifiable. So being female, over 50, having a family history, in particular a parent that has had a hip fracture, having a small or thin body frame is potentially not modifiable. We think of that as a BMI of less than 20 on average, so there's a lot of variability there. Um, being of Caucasian or Asian ethnicity and having early menopause or other unmodifiable risk factors. Some things that one might have more control over potentially are having a low calcium intake, vitamin D deficiency, a sedentary lifestyle, tobacco use, and excessive alcohol use. Some other risk factors for the development of osteoporosis, there's numerous medical conditions that can contribute to the development. List is not entirely exhaustive, but some of the more classic or common conditions, in particular things I want to point out that are particularly common and also within the rheumatologic realm in my world in rheumatology, commonly co-occur with osteoporosis or rheumatoid arthritis or really any inflammatory arthritis. The inflammatory process drives resorption of bone and osteoporosis. And then also diabetes, very common, some thyroid disease, in particular hyperthyroid, hyperparathyroidism, any process that involves, contributes to malabsorption can contribute to osteoporosis. So a classic example would be celiac disease, or a prior surgery in the stomach. So a gastrectomy or gastric bypass surgery would make osteoporosis more likely, potentially an inflammatory state in the bowels, and then vitamin D deficiency, another common thing. So, and not an exhaustive list, but some things to consider as risk factors. Aside from medical conditions, there's also medications that we give that can contribute to osteoporosis. The one bolded at the top are glucocorticoids or steroids. So this is by far the most offensive agent on the list. So high risk with this, and also something that is utilized in the field of rheumatology not infrequently. So there's a correlation there, but yeah, steroids make a much higher risk for osteoporosis. Other therapies that are fairly high risk are androgen deprivation therapy used in prostate cancer. Aromatase inhibitors used sometimes with breast cancer. More moderate risk, but still of note, are chronic use of SSRIs, anticonvulsants, or anti-seizure medications. Depo-provera is a injection birth control, and then less overall lower risk, but still of note, are proton pump inhibitors, the chronic use of them, in particular, loop diuretics and heparin. So how do we screen for osteoporosis? This would ideally be when it is picked up rather than after a fracture. But the way that we screen for osteoporosis is with a DEXA scan. So a DEXA scan is an X-ray that measures the bone density at particular sites in the body. It is very low radiation. The radiation obtained from one DEXA scan is less than a flight across the country. So, sometimes folks are concerned about that, but hopefully not too much of a deterrent. Um, it is recommended that all women over age 65 get a DEXA scan, all men over age 70, and then postmenopausal women under 65 with risk factors, whether that's one of the medical conditions or medications, or early menopause. So that would be a reason to screen. Men age 50 to 69 with risk factors, and anyone who has a fracture after the age of 50. So after a DEXA scan, there's various ways that you might receive your results, but this is one type of report that's often that people often receive. And just to briefly walk through this, if it's something you've seen or might see in the future, what it's showing here, this is a picture of the bone, the left hip bone in this case, and it's measuring the density of the bone in various locations, and those are detailed with the specific region is over here listed. And then of all the columns, the things that we pay attention to or to tune into are the BMD, which stands for bone mineral density, and then the T-score. Those are that's the information we use most from this. And then this box down here is reporting the fracture risk, and I'll speak about that in another moment. But from this information, when go into these different stages of disease. These are terms to know that have implications both for the risk of fracture as well as for treatment options. And this information is obtained from the DEXA scan. So the T-score tells you how many standard deviations above or below the young adult mean your bone density falls. So T-score of negative 1.0 to and above is normal. And then if you have a T-score between -1 and -2.5, that's in the category of osteopenia. Osteoporosis is defined by a T-score of less than or equal to -2.5 on the DEXA scan, or a history of a fragility fracture or osteoporotic fracture that I discussed earlier on. Severe osteoporosis is a definition we use, or a category that's described by having a very high risk for fracture related to either a T-score of less than or equal to -2.5 in the context of a fragility or osteoporotic fracture, or a T-score of less than or equal to -3 just by itself without necessarily having a fracture. Also in the context of multiple prior fragility fractures. Of note, the T-score is what the measurement we use to for most often. In rare cases, when a DEXA scan is obtained for someone younger than 50, we use the Z-score, which was another column on that report. For the context of this discussion, I'm not going to talk more about that because most of what I'm discussing here pertains to adults over age 50. Okay, so here we are looking at a slide that's just kind of recapping a lot of what I've covered so far, just another way to look at it and consider how we reach these diagnoses and the different categories. So in considering how we get to a diagnosis of osteoporosis, we ask first about any fracture history, a fragility fracture at any of these sites. If there has been a fragility fracture, is equivalent to osteoporosis. If not, we use the DEXA scan. We turn to the DEXA scan and look at the T-score. If it's less than or equal to -2.5 at the lumbar spine, total hip, or femoral neck, then that is consistent with osteoporosis. If the T-score is between -1 and -2.5, then we consider whether there is a high risk of fracture based on a risk calculator, which I'll speak about next. If the T-score is greater than -1, that's normal. And then if there is a high risk of fracture based on the calculator, then we would treat similar to osteoporosis, and if not, that's considered osteopenia. One caveat here, up here in this blue box, when we talk about the sites where where the T-score is less than negative 2.5, the lumbar spine, total hip, and femoral neck are typically the regions that are identified and reported in a DEXA scan. And there's particular reasons for that related to different types of bone and getting an overall sense of the bone density throughout the body by the combination of these sites. But there are certain cases when one of these sites cannot be used for an individual or should be considered in particular context. So in times they couldn't be used are if someone's had a hip replacement or extensive spinal surgery, then the hip and spine measurements respectively would not be reliable in that case and would not be checked. In that case, we would go to the distal third radius as a third site or a second site, depending on the number of replaced joints. So the distal 1/3 radius can also be used. Another caveat or thing to note rather with the DEXA score, the T-score, specific to the lumbar spine is that in cases of degenerative changes in the lumbar spine, which is quite common, particularly in older adults, the DEXA T-score number can overestimate the bone mineral density. Or the DEXA can overestimate the bone mineral density because of the degenerative changes. It picks it up as being more dense than it actually is. And so this can underestimate fracture risk. So it's not just as simple as the numbers, but the numbers guide us, but need to be taken in context. All right, so I mentioned the fracture risk calculator. So this is a tool that is used to help calculate the risk of a fracture. So what this it's called a FRAC score, and it's a well-validated tool that predicts the 10-year probability of having a fracture in a percentage. And so in the United States, we define high risk as a fracture, a 10-year probability of a hip fracture greater than 3%, or a major osteoporotic fracture greater than 20%. And so if we put in the information that is in this calculator and it comes out with major osteoporotic fracture greater than 20 or hip greater than 3, that would be a context that would be reasonable to discuss treatment options and recommended to discuss treatment options to prevent to lower the risk of a fracture. Some of the components here, if it's not very easy to see, are age, sex, weight and height, and then some of the things that we talked about as risk factors. So if there's been a previous fracture, if there's been a hip fracture in someone's parents, current smoking, steroid use, rheumatoid arthritis, secondary osteoporosis, which could be related to another underlying either medication or medical condition, heavy alcohol use, and then from there you put in the femoral neck bone mineral density, if that's available. If not, you can change that and get another variable. But that's sort of the tool that we use to help calculate the risk of a fracture and can guide discussions about what to do. All right, so just to take a little pause, we've talked about risk factors and definitions and screening. And so for the remainder of our time together, would like to focus on management and treatment options. So the huge part of management is related to lifestyle, and this is a part of the talk that pertains to anyone of any age, not just once one has osteoporosis or osteopenia. So ideally, this could be a preventable process, and doing these things can be helpful for bone density over the lifetime. So weight-bearing exercise is hugely important. This includes walking, hiking, dance, tennis, anything that's really using the force of gravity for that load bearing on your body, on your bones. Swimming and bicycling are great cardiovascular exercises, but do not count as your weight bearing exercise. So if that's your activity of choice, hopefully it could be accompanied by some strength training or other walking, hiking kind of activity. The reason for this is that the bodies or the bones really respond to mechanical stress. So when there is that stress on the bones, that signifies to your the cells on the cellular level to keep working on remodeling the bone and promoting bone formation, and limiting the amount of bone that gets kind of recycled and resorbed. So very important there. Strength training as well. And this is a little bit of a different mechanism that it supports the bone. But in considering strength training, it doesn't, these folks on the picture are doing some strength training. It can look like that, but it doesn't have to look like that. It can look like resistance bands. It can look like body weight exercises. Free weights are also great. Some people prefer weight machines. Any of that is fine. I'd say the biggest thing is to make sure you're doing it safely and in a gradual approach. If it's a new thing for you, not to go in too heavy, and consider working with a physical therapist or a trainer to make sure the exercises you're doing are safe. Some of the exercises I would try to avoid, in particular, if there already is some thinning of the bones or osteoporosis, would be significant like spinal flexion activities or a lot of twisting and rotational movements, at least to start out with, maybe build up to that, but those could be higher risk for if there were already a high risk for fracture. But I mentioned there's a different mechanism with the strength training, and that relates more to the where the muscles connect to the bones through the tendons, the force that is exerted in those types of movements from a muscular level, sort of the rotational forces and contraction forces, also signify to the bones to for bone formation and the remodeling that promotes formation of bone rather than resorption, and will strengthen the bones over time in a slightly different physics mechanism than the weight bearing exercise. Fall prevention is super important. So this includes kind of taking a pause and considering any limitations you might have. Sometimes that can be in the form of visual impairment or any neuropathy or limited mobility of any sort. If there's any of those things could make falls more likely. Your surrounding the area, the space in which you live, so different things in the home that could pose a fall risk. Obviously, there's things out in the world too that cannot always be controlled, but trying to do what you can to prevent falls. Use assistive devices if needed, wear supportive footwear, have good lighting in your home, remove tripping hazards. If there are issues with balance and stability, there's a type of balance and stability training that could be done on a lot of the kind of stabilizing muscles and working on that. There are also services through some of the therapy groups that can come to your home and do like a home safety assessment if that's a concern. So all of those are options to consider in trying to prevent a fall. Furthermore, as far as other things you can do, limit alcohol intake, and if you do smoke, um, stop smoking for your bone health, as well as many other reasons. All right, moving on to another topic of supplements and nutritional factors that contribute to bone health. So the mainstay for bone health is calcium and vitamin D. So that's the kind of the tenets that we need to focus on throughout the lifetime, but also in the setting of osteoporosis. Calcium, the goal is to get about 1,200 milligrams a day for most adults. And this is, if at all possible, to get through diet. I strongly encourage people to do it that way. It is better absorbed when it's through dietary sources. That's a short list of some diet. Obviously, there's calcium in dairy products, but even for people who don't take dairy, there's many other food sources, dietary sources, and so it might require some intention. But there are online calculators that can help you put in sort of your average diet and get a sense of how you could obtain that through diet. If it truly is not attainable for you through diet, then there are supplements of calcium available. The two most common general categories are calcium carbonate and calcium citrate. So calcium carbonate would be things like Tums, Caltrate, and Oscal are some of the names. And then calcium citrate is another formulation that can be used. And then as far as vitamin D, there's not a one size fits all answer to how much vitamin D you need to take in. There's a lot of individual factors that can change what your vitamin D level might be. The biggest factor, the best source of vitamin D is through the sunlight, and so that can, depending how much sunlight you get and what type of skin you have and how your body absorbs that, can contribute to your level of vitamin D kind of naturally. There are some dietary sources, though it would be hard to get all the vitamin D you need through diet alone, but fatty fish, egg yolks have some vitamin D in it. It's very common that someone would benefit from supplementation in the setting of osteoporosis or osteopenia to make sure that their vitamin D is adequate. And the reason we need vitamin D is to help the body absorb calcium. So I wrote 800 IU international units daily as a guide here, but again, there is a large range of what someone might need. In general, it's discouraged to take more than 4,000 international units a day, unless there's a particular extenuating circumstance or condition that makes that necessary, but would certainly not advise doing that unless it's being closely monitored and guided by someone for a particular reason. Other things, kind of general healthy things, proteins are good for bone structure, important for that. Magnesium is a helpful nutrient that helps with calcium absorption. And then vitamin K is also an important component for bone formation, found in leafy greens, and broccoli are great sources. Okay, so moving on to medications that we have. Before getting into the nitty gritty of the specifics of medications, just want to recap indications for pharmacologic treatment on the whole, that we kind of break this into two categories. The first is for primary fracture prevention. And so this is a case if you've never had a fracture, an osteoporotic fracture, but do have a T-score less than or equal to negative 2.5, again, diagnostic of osteoporosis by DEXA scan, or if you have osteopenia with a high fracture risk score. So that would all be for primary prevention and a reason to consider treatments, pharmacologic treatments. Also in the setting of secondary fracture prevention, so you've had a fracture before, either if in the hip or the vertebrae, regardless of the bone mineral density, it would be an indication for treatment. Or if there's osteopenia on a DEXA scan and a prior fracture of one of a non-vertebral or hip site. And these are, again, guidelines. There are individual circumstances that might change the consideration of whether to treat or not, but on the whole, this is what we think about. But it's certainly, I think, if there's any one takeaway from this, I hope that it's that treatment regimens should be and can be individualized. There's a lot of factors that might go into considering what treatment approach might be best for you. So again, one last thing before we get into the particular agents, just wanted to introduce this concept that I've mentioned a few times but haven't truly defined yet. So bone remodeling is a natural constant cycle in our bodies where old and or damaged bone tissue is removed and replaced with new bone tissue. This happens throughout the adult life, and when bone formation occurs in about an equal amount as bone resorption, our bones are in homeostasis, or it's kind of an equal balance. When this balance is disrupted, osteoporosis can develop, in particular when the bone resorption outweighs the formation of bone. So this is a complex process in the body, and this diagram is is a simplified version of what happens. But for the purpose of this talk, I'd like to highlight two cell types, as I think they can hopefully help with understanding how our medications work and the targets. The two cell types are the orange cells here called osteoblasts, which are active in bone formation. So remember this by blast and build. They help build the bone. And then the purple cells here represent osteoclasts, which are a type of cell that help with bone resorption, or kind of consuming the bone, chewing the bone, classed chew. So one way to remember it, but those are kind of some of the targets and different mediators related to those cells that we target for treatment of osteoporosis. Okay, so two broad categories of pharmacologic therapies. The first is anti-resorptive therapies, and then there are several within that broader class. Anti-resorptive medications work by slowing down the breakdown of bone. So they inhibit the osteoclasts, which were those purple cells, the bone chewers, so that in effect, the bone is preserved for longer. Anabolic medications, the second broad category, work by actually building new bone. So they stimulate the osteoblasts for more building, and that can increase the bone density. Typically, anabolic medications, historically and most commonly, are used for severe cases. So I will speak a little bit more about each medication with a caveat that I will say some of the more common side effects that we see or hear about with them. This is not an exhaustive list, and but just to note, I'll mention a few of them that come up more often. And then in subsequent slides, when I speak about the fracture risk reduction, that refers to the percentage of reduced risk of a new fracture compared to a placebo. So the time frame of that depends on the particular medication and study and how that was done. All right, so bisphosphonate medications, these have been around for a very long time. They are well studied with decades of safety data. They're very affordable, often first-line therapy. They work by, they have a high affinity for the osteoclasts, the purple cells that chew up bone, and they promote death of those cells. They are available in both oral and there's several oral options within the bisphosphonate class. Most commonly, we use alendronate or Fosamax, which is a pill taken once a week. There's also Actonil and Boniva that are oral pills. And then there's one IV form of a bisphosphonate, which is zoledronic acid or Reclast, and that's an infusion medication given once a year. As far as potential side effects, the probably most common thing that comes up is GI upset, in particular like worsening or a new acid reflux, or issues with swallowing. That occurs in about 20 to 30% of people taking the oral form of bisphosphonate. Does not occur with the IV. So that is one of the reasons we might start with the IV if someone does have bad, issues with swallowing or a stricture, or severe GERD, could be reasons to consider skipping the oral and going right to IV. Sometimes people report joint or muscle pain, and we also monitor for potential low calcium. These medications are not safe to be used in the setting of kidney disease, so that's a consideration. But again, these medications work well and have caused, with them, we see a progressive increase in bone mineral density over the first 3 or 4 years and after treatment, and then that sort of plateaus. The magnitude of increase, how quickly that increases, depends on which agent. There's different data for different agents. And is generally better in the spine where there's more bone turnover. So there tends to be more fracture risk reduction in the vertebrae relative to other sites. And that's true across most of therapies. So fracture risk reduction, the range here is because there's multiple agents included in this class, but vertebral fracture risk reduction of 50 to 70%, hip fracture risk reduction of 30 to 50%, and non-vertebral fractures 20 to 30%. All right, next up we have the RANKL inhibitor. There's one medication in this class called denosumab or Prolia. This is another anti-resorptive medication and given as an injection every 6 months. It works by blocking a protein that activates the osteoclasts. That protein is the RANKL protein. And so that's how it leads to less osteoclast activity. There is a risk, very important to note with Prolia, there's a risk of rebound fracture. And so this happens because the treatment effects the way the medication works when after stopping it, there's a rapid offset after discontinuing. So 6 months after the last injection, if you're not getting another injection, there will be increased risk of vertebral fractures in particular. And so it is recommended that therapy with Prolia either be continued indefinitely or that it be followed after with another anti-resorptive medication, specifically a bisphosphonate. So this is something that's really important to consider, and I like to have this discussion with people from the offset because it is oftentimes the reason why someone might be interested in Prolia or considering it is because they've heard other things about bisphosphonates or don't want that class, but it really should be approached with some consideration and thought about the long-term plan. So in particular, in younger people with osteoporosis, starting this without a good plan of when to stop it and how to stop it is, that's an important thing to consider. With Prolia, though, so it does work very well that we see an increase in bone mineral density that is more profound than with bisphosphonates. So there's a larger increase in general. And that continues over the course of it's been studied out to 10 years, and that continues over the course of 10 years. So it does not plateau in that way. Interestingly, though, the fracture reduction risk is a little better, but not that dissimilar from the bisphosphonates. So the actual fracture risk reduction for vertebral fractures is 68%, hip fractures 40%, and non-vertebral fractures 20%. Right. Estrogen therapies are another anti-resorptive. Estrogen naturally in the body is fundamentally an anti-resorptive hormone. It increases bone formation and decreases bone resorption. Both men and women do have estrogen. In men, testosterone is converted to estrogen in the bones. So, but as far as it being utilized as a therapy for osteoporosis, we consider it in kind of two different things. One is estrogen therapy, like a hormone replacement therapy, and there's various formulations of this. The study that this fracture reduction pertains to was using conjugated equine estrogen, but the vertebral and hip fracture reduction was 34%. And then selective estrogen receptor modulators, raloxifene is the one we have in the States. This is called Evista is the other name for it. And this is a daily pill that mimics estrogen's bone protective effects. It's a good option to consider, in particular if someone is high risk for breast cancer, because can lower the risk of breast cancer. It does, however, carry with it a risk of a blood clot, so important to be aware of and monitor for and consider with someone's history. As far as fracture risk reduction here, it reduces the risk of a vertebral fracture 30 to 50%, but has no effect for non-vertebral fractures. So overall for estrogen therapies, the takeaway would be there's a lower fracture risk reduction compared to other antiresorptives, and would typically reserve it for a case where the other antiresorptives cannot be used for some reason, or in a more mild case when someone has another indication to be on one of these medications and also has some thinning of the bones or early osteoporosis would be a consideration. Next up is, now we're moving into the anabolic category. So this is a sclerostin inhibitor called romosozumab or Evenity. This is the newest medication we have available for osteoporosis, and it has both anti-resorptive and anabolic properties. So it's the only dual action therapy we have that both builds bone and slows down the breakdown simultaneously. It is given as a monthly injection for a year. And it works very quickly. It's limited to 1 year because after a year of use, there's a waning of the bone forming effects. So it really is most effective in that first year. And after that, it's recommended to follow with anti-resorptive therapy, either Prolia or bisphosphonate medication to maintain whatever gains in bone mineral density there have been. And so that's the way to use this would be by following with another agent after a year. Tends to be very well tolerated. There's some reports of joint pain and headache, but the main thing to consider is it should be avoided if there's been a recent heart attack or stroke. Usually saying within the last year is what I would consider recent, but obviously will individualize this. It has a fracture risk reduction of vertebral fractures by 73% and non-vertebral for 25%. So this is a great option for severe osteoporosis. And another option for that same category of severe osteoporosis is the other anabolic agents we have, which are parathyroid hormone analogs. The ones on the market are teriparatide or Forteo, and abaloparatide or Tymlos is the other name for that. These are both daily injections that are given for up to 2 years. After their use, they should be followed by anti-resorptive therapy. Again, they have bone building properties, but any gains that are made in the 2 years of the 1 to 2 years of the course will be lost after stopping, if not followed by something else to maintain that improvement in bone density. Potential side effects here include nausea, dizziness, headaches, palpitations, and a high calcium level, so need to monitor for those things. It should be avoided if there is a history of osteosarcoma. And the fracture risk reduction here is a vertebral fracture of 65 to 85% and non-vertebral 35 to 53%. This slide pertains to some possible adverse events with anti-resorptive therapies, in particular the bisphosphonates, denosumab or Prolia, as well as romosozumab or Evenity. Both of these very rare adverse events have been seen with all of these medications I just mentioned. So they include osteonecrosis of the jaw and an atypical femur fracture. Um, the rate of these are very, very low. It's less than 1 in 10,000. It's between 1 in 10,000 and 1 in 100,000 people that develop osteonecrosis of the jaw. It's when the jawbone is persistently exposed. Increased risk occurs with chronic bisphosphonate treatment for more than 5 years without a drug holiday. But again, has been reported with other agents as well. It's important to have routine dental care and good oral hygiene. And beyond that, though, there's individual considerations, but by and large, the takeaway regarding these things are that the risk of fracture associated with not treating your osteoporosis, it far exceeds the risk for these very rare adverse effects. Um, just briefly, this slide is sort of just a visual representation of some of the numbers and data I just shared in the prior slides about the fracture risk reduction. All of these are the medications on the left, and all of them have do have improvement for treatment. There's a reason to treat. They are better than not being on treatment. So the effect of the medication is different depending on which medication it is. But for the sake of time, I'm not going to go too much into the detail there. Monitoring disease and treatment. So it's important to get labs at baseline to assess for any underlying conditions that might be contributing to osteoporosis. Check a vitamin D level that should be at least 30 before any treatment is started. And then also intermittently, depending on the medication, would obtain labs to monitor. Typically, we get DEXA scan usually every 2 years. That's what's most often covered by insurance. There are some compelling reasons to do it more often that we can try to get, but in general, every 2 years, ideally would be done on the same machine. It is important to regularly reassess fracture risk. So if there's any major changes that might put you at a higher risk for fracture, that should be discussed and considered. It's important to talk about drug holidays and consider that in the overall treatment approach. Typically, we use drug holidays with bisphosphonate medications. And then retreatment is something to be considered too. So anti-fracture therapies, all of the ones I spoke about, do not cure osteoporosis. The skeletal deterioration will recur sooner or later when a medication is discontinued. So the treatment it's a big picture chronic condition to manage over time with probably a combination of therapies. All right, so just to wrap up here, osteoporosis weakens bones and increases fracture risk. It is silent, so very important to get screened. Calcium and vitamin D are essential for bone health. Weight-bearing exercise and strength training can help maintain bone density. And there's several medications we have to reduce fracture risk through various mechanisms. And it is something that requires lifelong management. Here's some resources that with some really great patient resources available if you're interested in it, and some references from today's talk. And that is all I have. So I will take some questions at this time.
Thank you, Dr. Stull. That was a really good presentation. So we have several questions that were submitted already, but a reminder for those of you who haven't submitted a question, please submit your questions through the Q&A box. And I will kick us off with our first question, which is, what role does hormone replacement therapy play in reducing osteoporosis risk or improving bone density? And what dose of an well, it's a two-piece question. I'll ask the first part and then I'll ask the second. So,
So what role does hormone replacement therapy? So as I mentioned in the slide with estrogen, so it can be used as an estrogen-based therapy as part of hormone replacement therapy, potentially with progesterone therapy as well. Can be is supportive of bone density. If you have osteoporosis and or a prior fracture, other medications have better data for improvement in bone mineral density. So in that sense, it's not first line. But particularly if there's another indication to be on it, there hasn't been a fracture before, there's not severe osteoporosis, and it's otherwise safe and appropriate for you to be on hormone replacement therapy, then it can be a good adjunct. But it's not something that typically I would start primarily for that reason. If you're just doing it for osteoporosis, there are other medications that are have better efficacy.
okay, great. The second part of the question is, what dose of an estrogen patch is typically used for bone protection? Or does the dose vary by person?
I think there are some specifics about dosing. That's not something I prescribe in my clinic, so I'm not familiar with the specifics. I don't know the data on the specific of the dose, and I know there's various formulations of estrogen. So I would defer that to someone who prescribes hormone replacement therapy.
Okay, great. Thank you. On to our next question. Some people experience digestive side effects like constipation with calcium supplements. Are there forms that may be easier to tolerate, and which types are most efficiently absorbed by the body?
Yeah, so as far as supplementation with calcium, I mentioned the calcium carbonate and calcium citrate are the most common. Both can cause GI upset, but that tends to be the constipation in particular tends to be worse with calcium carbonate. So calcium carbonate again is what we see what's in Tums and Oscal and Caltrate. So if constipation is an issue with supplementation, but you're unable to get it through the diet, through enough calcium from dietary sources alone, then would try calcium citrate. This has a lower amount of elemental calcium, so you need more pills to get to the 1200 milligrams. But nonetheless, that is a reasonable option if their constipation has a side effect. It can also be more effective for some people with certain conditions. If you're not able to eat normally, or it's okay to take calcium citrate without food, whereas with calcium carbonate, that should be taken with food. The calcium carbonate needs stomach acid to break down and be absorbed. Calcium citrate does not. So if you're taking pills without food, use calcium citrate. Also, if you have to be on a PPI or an acid reducing medication like an H2 blocker, that would be another reason to opt for calcium citrate rather than calcium carbonate.
Okay, great. That's very helpful. Our next question, and you talked about vitamin D in your presentation. But the question is, what vitamin D3 blood level is considered optimal for bone health?
So I don't have there's not an answer. There's not great data of an answer for that outside of the context of therapy. So when giving medications, we use a serum vitamin D level, want it to be at least 30 or greater. Um, there's conflicting data about whether like a specific level otherwise. I tend to say 30 is it's a good goal. That's what we would want you to be at if we were going to start treatment because of the way the medications work and needing that amount of vitamin D so that it can actually improve the bones. But yeah, so say 30, and the other end of that I would note as far as a particular number is that a level above 100 is not advised. So it is vitamin D is a fat soluble vitamin, so it is possible to have vitamin D toxicity. You can store too much in your body. Um, so if you're taking too much and your level is over 100, there have been studies that show adverse effects related to that, in different several different adverse events, but also as it pertains to bone health, because that can lead to too high vitamin D can lead to too high calcium, and that can actually contribute to a more bone resorption then, which is not what you want. So.
No, that is all great to know. Thank you. Is daily walking 1 mile enough for weight-bearing exercises?
Um, I don't have an answer to like exactly how many steps. It depends. There's a lot of factors in that. It's 1 mile. Walking 1 mile a day is certainly better than not walking 1 mile a day. I think that in combination with periodic strength training is, depending on, is a great place to start. And is if that's what you're able to do, that's great.
Okay, perfect. How does scoliosis affect bone density measurement and the accuracy of DEXA scan results?
So scoliosis could contribute to, there's often more degenerative disease, especially later in life if you have scoliosis, degenerative disease, and there could be a falsely increased bone mineral density reading. So it would read it as more dense than the bone actually is because of degenerative changes there. So really the important thing, or unimportant thing with bone density, or with bone health and fracture risk, is not just the density of the bone, although that's a lot of what we talked about in how we screen for things. It's also really important to consider the microarchitecture of the bone. And that's something that the DEXA scan is not as good at picking up. So that's a little bit of an aside, but basically just that there's multiple factors. But the question related to scoliosis is that it could falsely elevate the bone mineral density reading if there's degenerative disease with that.
Okay, thank you. Are there ultrasound-based tests for osteoporosis that provide information about bone structure? And are those available here in Santa Barbara?
Not to my knowledge.
Okay, great. Let's see, our next question. This one goes back to supplements. Is magnesium glycinate beneficial for bone health? And if so, how much is typically recommended?
It's not one of the core things. I think calcium and vitamin D are really where I would put your money, but magnesium is helpful in that it helps with calcium absorption. So, and there are different formulations of magnesium. I think any of them could help with calcium absorption. So, I would say whatever. I don't know the specific doses of magnesium off the top of my head to say the dose, but
Gotcha.
it can help with calcium absorption.
Okay, great. So you mentioned some advantages of Prolia over medications like Fosamax. Could you elaborate on how they differ, particularly in terms of fracture risk reduction?
Yes, so their fracture risk reduction is actually not that dissimilar. Going back to my slide with the numbers aren't that dissimilar. The way they differ in a few ways. One is that the I think the main thing is that with the Fosamax or alendronate, the bisphosphonate medication, that the bone mineral density increases gradually over 3 to 4 years and then plateaus at 3 to 4 years. And then it still stays up if you're continuing on it, but it doesn't keep going up, plateaus. With Prolia or denosumab, the bone mineral density goes up and it continues to go up for up as long as it's been studied, and the studies are up to 10 years. So that will continue to increase. So the alendronate plateaus and the denosumab keeps going up. So again, that's the bone mineral density. So there is the difference with that, but the actual, as it correlates to the fracture risk, there is, it's not the same like difference in linear versus plateau effect of fracture risk.
Gotcha. Alrighty, our next question is a question that I myself also have. Are carbonated beverages detrimental to bone health?
I've looked into this because I've heard that too. So there's probably something to it. I think it relates more to the absorption of some of the minerals and osteoid, you know, building of bone, and that there can be like the thought of leaching some phosphorus and calcium if you're from those medications, potentially not being as well absorbed. So there's not great data about it that I've been able to find. There's not any data about it that I've been able to find, but it is something that's mentioned. So I tend to advise moderation.
Moderation. Everything in moderation.
Yes, exactly. Same with caffeine as it pertains to bone density. Yes, I think some is okay. A ton is not great.
Okay. We've received a couple of questions on this topic. Some gyms, such as OsteoStrong, focus on bone health and claim their specialized equipment can help increase bone density. What is your perspective on programs like this, compared with traditional weight training, let's say at home or at another gym?
Yeah, I think it's there's something called, I think it's called Bone Fit. There's a particular training that's through the Bone Health and Osteoporosis Foundation. They have a training for therapists, physical therapists, trainers that someone can take. It's like a trademarked, I think it is Bone Fit. And so that's the only, I'm familiar with that and the techniques of that. I don't know of any particular special equipment with that. I think in general, you know, the point is to be doing the activities, and I think it's great that there's a program available for that can supervise it. I think of the barrier for a lot of people, especially if they haven't done strength training over many years or are starting it later in life, is that it can be intimidating and there's a lot of options and not sure where to start. So I think that that's a great option. I don't know if they're I don't know if you said they're available in Santa Barbara. I don't know personally, but yes, so I think could be a great option, but not necessary. It is also possible to do the things that your bones will need from home with minimal equipment. And so there's lots of ways to get to the end point. There's no, I don't believe there is a secret one piece of equipment that will improve bone density. I don't think that exists. If there's claims of that, I would question it. I think it's really a combination of the things of weight bearing exercise, of various strength training, balance training, that when put together will optimize bone density and bone health.
Okay, perfect. Well, we are coming to the end of our time here. It's all been so insightful, and we have a few questions we're not going to get to, but I will ask us one last question and then we'll wrap it up here. Um, I think this is a good one, kind of falls in line with what we just talked about. Can lifting weights in general and exercise improve bone density and not just maintain it? Or what do you advise?
Yeah, yeah, it can improve it. And so it definitely can, especially if it's done. I wouldn't say heavy lifting, but the time in life in adolescence when bone increases to its peak bone mass in young adulthood. That's a time when activity and load bearing and weight bearing can be particularly helpful to reach that peak bone mass, and improve bone density, so that your starting point, so to speak, knowing that with time, hormonal changes, bone density, the natural course is to lose bone density. So starting at a higher peak would be, there is the way to improve it that way. And I think probably more what pertains to this discussion is in the setting of osteopenia or osteoporosis, lifting and strength training can improve bone density. It does work on the bone formation. The it would be, I think, possible to outpace the bone resorption, but the natural history of untreated osteoporosis, or osteopenia is the continued loss. So the natural progress process is to lose about 2% of bone mineral density a year. So I think if you can stay even with your activity, that would be really, show that it's been a supportive thing for your bone density. And I think it's probably possible to improve, but um, usually it's part of the picture. It alone would be, I think, more difficult.
Great. Well, that concludes our Q&A. Thank you so much for your time. And thank you everyone for your questions and for joining us this afternoon. Cottage Rheumatology Clinic is located at 2320 Bath Street, Suite 315 in Santa Barbara. We will email a recording of this presentation in the coming days. If you have further questions or would like more information, you can always call 805-569-7236 or visit cottagehealth.org/rheumatology. Please note Dr. Stull's clinic has had a great response from the community. So that being said, when you call to make an appointment, you may be placed on a wait list. The clinic is working to increase some availability. And lastly, a brief survey will appear after this webinar closes, and we'd love to hear your thoughts. And thank you again for joining, and have a happy and healthy rest of your day.